Wait, did we have some sort of relationship with him?
I think they're just like that. I think they're just good guys.
Oh.
In the human body, the liver is one of the most crucial organs. The liver's primary functions consist of filtering blood from the digestive tract, detoxifying chemicals and metabolizing drugs, as well as secreting bile that enters back into the intestines. Hepatitis C is a blood-transported virus that infects the liver, replicates within its cells, can cause inflammation and significant damage to hepatocytes or liver cells. Clinical manifestation can occur typically within 7 to 8 weeks after exposure to HCV and is usually spread when blood from a person infected with hepatitis C enters another person's body. The pathogenetic progression and expression of the HCV genotype is highly variable, as 6 different genotypes of HCV result in varying severity of the infection, which include acute infection or persistent virus replication, yielding to chronic infection. Acute infection is largely characterized by symptoms such as fever, nausea, vomiting, abdominal pain, dark urine, joint pain, and jaundice. The symptoms from this infection vary, as a majority of people do not see symptoms, especially in the beginning weeks. We sometimes see fulminant hepatitis, though it is very rare. In the beginning of acute infection, the patient undergoes early experiences of mild fibrosis, slight scarring of liver tissue by excessive accumulation of extracellular matrix. Fibrogenesis is balanced by fibrolysis, the removal of excess extracellular matrix by proteolytic enzymes, and assists in preventing the progression to chronic infection. Steatosis has shown that liver lipid overload can contribute to the development of fibrosis in 50% of the patients. In response to acute infection, the first immune cells that counter HCVs include natural killer cells and immature dendritic cells, which are activated by hepatitis C viral antigens. The mature dendritic cells can further induce natural killer cell activation, which increases production of IL-10 and TGF-beta. HCV-specific T cells, such as CD4 helper cells and CD8 killer cells, are recruited to the liver after 4 to 8 weeks, and they target multiple epitopes within different HCV proteins. IFN gamma, or type 2 IFN, is produced by Th1 cells and induces TC cells during the adaptive response. HCV replication is inhibited by IFN gamma mediated and cytolytic mechanisms. T cell induction of interferon gamma clears HCV. Poor response to the IFN gamma is what allows continuation of the viral replication. CD4 plus T cells are central regulators, while CD8 plus T cells are virus specific that function as key effectors. CD8 plus T cells inhibit viral replication by secreting perforin and IFN gamma and Fas cell binding. CD8 plus can either directly lyse infected cells or secrete cytokines that inhibit viral replication. CD4 plus cells can also induce antibody production by plasma cells via secretion of cytokines that specifically target HCVs. Neutralizing antibodies block HCV from binding into hepatocytes. In about 30% of patients, the immune response is strong enough to get rid of HCV in acute hepatitis C. If this is unsuccessful, the virus will progress on toward chronic infection. Chronic infection appears after the virus has persisted in the host for more than 6 months after the initial infection. Because of the lack of symptoms, approximately 70 to 80% of patients infected with HCV will develop chronic infection through advanced fibrosis that can eventually lead to cirrhosis, liver cancer, and then liver failure. When innate immune responses are weakened, direct antiviral effects and the priming of adaptive responses decreases, which leads to the persistence of HCV. Chronic infection can also result from T cell failure due to T cell exhaustion and viral escape mutations. Damaged killer T cells may be due to low numbers of damaged antigen-presenting cells such as macrophages and dendritic cells. Functionally impaired CD8 plus T cells are unable to secrete antiviral cytokines such as IFN gamma or proliferate. Subsequently, the lack of CD4 plus T cells help is caused by limited TCR diversity, dysfunctional CD8 plus T cells, and viral fitness. Additionally, regulatory T cells suppresses killer T cells from inhibiting viral replication by expressing IL-10 cytokines that will block the TC cells. Severe cases and death can happen, but only a small percentage of people of those infected will get serious illness from the disease. This only occurs in people with cirrhosis and 15 to 20% of those infected cases. Cirrhosis is chronic liver damage from scarring of the tissue due to accumulated fibrogenesis and is a major prognostic risk factor. Scar tissue replaces healthy liver cells, which are needed to perform liver functions, interrupt with blood flow to the liver, causing the cells to die and form more scar tissue. Patients infected early in life have much higher mortality rates, especially those less than 50 years old, and several studies showed that these cirrhotic patients have a six-fold increase in mortality compared to a matched general population. Alcohol consumption, obesity, and co-infection with HIV have also been shown to increase the progression of cirrhosis and induce greater susceptibility to liver disease. Children and young women have the best chance of resolution, while infected men are more likely to develop chronic cirrhosis and liver lesion. Prolonged and excessive cirrhosis can eventually lead to hepatocellular carcinoma, HCC, which is hepatocyte inflammation that can result in liver cancer. Pathogenesis overproduces the virus and accumulates toxic components in the surface antigen within the liver cells, which develop severe prolonged hepatocellular damage that initiates a programmed response within the liver characterized by inflammation, regenerative hypoplasia, and aneuploidy progresses to neoplasia. Once the infection reaches the state, the only treatment option is a liver transplant. However, careful monitoring must be done to make sure that any HCV in the blood doesn't reignite the infection. Estimated number of acute infections per year in the U.S. is 38,000, chronic 2,700,000. Estimated number of chronically infected persons in the world, 178 million. Unfortunately, a successful HCV vaccine has yet to be developed. The individuals most at risk for hepatitis C infections are those with the following risk factors: injection drugs, chronic hemodialysis, persistent abnormal alanine aminotransferase levels, donated blood from person with a positive HCV test, HIV, men-to-men sex, and pregnant women. The three main subgroups of people living with the virus may have lower chance of a cure with today's available regimens. People with cirrhosis who were previously treated unsuccessfully with interferon-based Hep C regimens, people with decompensated cirrhosis, and those with genotype 3 of Hep C, especially those with cirrhosis. There are also subgroups for whom no Hep C treatments has been specifically approved. Treatment for HCV has undergone variation throughout the years. Since HCV infection resulted in inadequate interferon production, the initial treatment of hepatitis C was IFN alpha monotherapy. The therapy consisted of injections of interferon alpha and ribavirin as weekly doses. Over 90% of patients can be cured with IFN alpha monotherapy because HCV is very vulnerable to recombinant IFN alpha during the acute phase. This became outdated, however, as interferon therapy patients did not experience a reduction in chronic HCC development. The cause of this was the presence of the NS5A candidate HCV protein. The expression of NS5A inhibits the antiviral effects of RNA-stimulated protein kinase on interferon stimulation, inducing IFN resistance. Recent studies in Japan have shown that the extent of NS5A mutations are dependent on HCV genotype, with HCV1B being the most prevalent and the primary positive respondent to interferon therapy. Interferon therapy eventually went out of practice because of its dual effects on HCV infection, where it expressed both antiviral and anti-proliferate effects of the hepatocytes, and also executed a slightly protective effect of HCC development. The recommended treatment for HCV are all oral medications. These pills called antiviral medications are usually taken once per day and are extremely good at attacking the virus and preventing it from multiplying. Antiviral medications destroy the ability to reproduce, so the amount of virus in the bloodstream then decreases. The quantified amount of virus in the blood is measured by viral load, HCV RNA. Treatment is successful when the viral load drops to undetectable levels, which means the virus cannot be detected in the bloodstream at all. The viral load becomes undetectable during treatment and remains undetected after treatment has ended. If there is still no detectable virus in the blood 12 weeks after the end of the treatment was successful. This is called sustained virological response. A patient who has achieved an SFR is considered to be cured of the hepatitis C virus. The antiviral treatments are categorized as first-line, second-line options, and alternative options. Each of these treatment options consists of combinations of medical drugs. For instance, in first-line options, the treatment regimen of Zabadavir consists of the drugs Elbasavir and Grazoprevir. Other first-line options include regimens of Mevirite, Harvoni, and Epclusa. The second-line Vosavir regimen consists of Sofosbuvir, Felbutazivir, and Voxelprevir. Alternative options are not used as often as the first and second-line recommended regimens, as these have potential disadvantages and limitations in certain populations. These include unfavorable tolerability and toxicity and longer treatment duration. Of the pharmaceutical companies and the manufacturers that provide antiviral drugs of hepatitis C patients, the most prominent ones are Gilead, Janssen Pharmaceuticals, Merck, and Bristol Myers Squibb. Pharmacet is a pharmaceutical company that was bought by Gilead. Recently, they invented a drug to combat Hep C called Sofosbuvir. It is combined with other medications such as ribavirin and interferon. In a large study, 295 out of 327 patients treated with this had no signs of HCV in their blood after 12 weeks. In another study, 67% of patients had no signs of HCV in their blood after taking the medication for 12 weeks, which is the same result as 24 weeks of interferon plus ribavirin. Sofosbuvir resemble nucleotides that insert themselves into the virus's genes, interfering with viral replication. It is still expensive for most people, though. One point of great importance is IFN gamma therapy. It's unknown why IFN gamma succeeds in eliminating HCV in some patients, but type 1 or 3 IFN systems fail in the early stages of acute Hep C. Our hypothesis reads as such. HCV might have developed a strategy to avoid type 1 IFN by blocking PKR protein kinase R, an enzyme that inhibits viral translation. Also, type 3 IFN is restricted to the respiratory and gastrointestinal tract, so it may not be present in defending the liver from HCV. Type 1 are virus-induced, so they require PRR-BIMP binding and is usually involved in the innate response. IFN gamma is not virally induced, and it is secreted by T cells and NK and natural killer cells, and is usually involved in the adaptive response. One lab technique utilized in the study is intraviral imaging, which is used to observe the hepatitis-infected liver. Transcription factor staining is also used to know how HCV blocks PKR-IFN-mediated innate immune response.